Thanks for joining today. I'm excited to be here. I was actually scheduled to give a talk, I think in like mid 2020 when COVID happened and schools shut down and I have elementary age kids. So like I postponed it and it took this long to get it rescheduled. But I'm glad to finally have the chance to talk about my research in diabetes and virtual care. And most of the work I'm going to be talking about today is work I've done in collaboration with long-term collaborators I've had at Kaiser Permanente, Northern California. So is everything okay on Zoom now?
Yes, everything's okay.
Okay. So telehealth, broadly defined by the Department of Health and Human Services, is pretty broad. It's any use of electronic information and telecommunications that supports clinical care for patients and professional. It would be for education, for public health, for health administration, but it also includes things that we traditionally think of as telehealth, like video visits and secure messaging and things like that. But there's been a lot of variation in terms of how telehealth is covered from state to state, and more so before COVID. We'll talk about that. But includes things like what we think of traditionally as telehealth, which is synchronous visit, either like a phone audio only visit or with a video. Also store and forward, where you have secure messaging, or there's newer modes of care like e-visits that you can do that fall into this category. And then more and more, there's also more remote patient monitoring. And so that is when patients use some sort of device to monitor some metric from home. It could be either like patient-reported outcomes, or for patients with diabetes, it could be a continuous glucose monitor that monitors their blood sugar. And then, for all of these types of telehealth, you can either access them from a computer or from a mobile device. And anything that's done through a mobile device or through one of those remote monitoring devices falls in the category of mobile health. And then in terms of like what gets covered, that has varied a lot. And it used to vary a lot more before COVID, but the types of services that are covered, depends like where you are. I think before COVID, there were a lot of restrictions on having to be on a designated like healthcare facility to be able to access telehealth. There's comments. Or the type of provider you can see, or you have to be in a rural location seeing a specific like specialist that is hard to access through in-person services. And also differences about, like will they cover like store and forward, secure messaging, or audio only visits. So just a lot of variation. But a lot of benefits to telehealth. I think the main benefits that we usually think about are when we think about barriers to in-person care. If you have to make arrangements to take time off work, usually it requires a lot of travel time, wait times. Where a telehealth visit can be very quick, and especially if you think about like a secure messaging, like you can do it, at midnight, anytime, and it's very, very convenient. And it can increase patient engagement. Generally, there's been high interest and satisfaction from patients in being able to access care in this way. It's also a good way to engage family and other caregivers, especially if they don't live with you. Right? If you're helping take care of like a parent, they can join, from another state and still be able to participate. And then during COVID, as we all know, it was a huge benefit to be able to access care while preventing the spread of germs and mitigating the risks to both healthcare providers and people who are sick. But there's been a lot of barriers to telehealth, and before COVID, access was very, very limited. And we talked about some of these barriers, but like the main ones is reimbursement. There wasn't consistent reimbursement for telehealth visits for all providers, and so most providers, unless you were designed to provide services to like rural patients for very specialized services, like weren't offering telehealth regularly to most of their patients. They didn't know how to do it. They didn't have the setup and the training to do it. And then another big concern when we're thinking about telehealth is understanding the digital divide and how that can impact access to care. And this also was got a lot more attention during COVID because everyone, had to have the internet and connected devices to be able to do school and get healthcare, like do all of the daily functions that they needed to survive. And so basically the digital divide is just the gap between people who have connected technologies and those who don't, and that can vary by socioeconomic groups, by where you live, and it can have implications for, getting healthcare, education, job opportunities. So it's important to understand. And so thinking about like some big policy drivers of telehealth in the last couple of decades. Like the first big one was high tech, which was part of the stimulus bill in 2009, which provided millions of dollars in payments for providers to implement and use certified electronic health record systems. And part of that criteria was having systems that had an integrated patient portal. And then there's been, some more policies more recent, and of course we know the pandemic is what that propelled everybody to start offering telehealth and getting patients to actually start using it. And most of the research that I'm talking about today was in at Kaiser, and I think Kaiser is a great place to study virtual care and telehealth because they've always been just that early innovator in the space, and they implemented the Epic EHR system starting in 2006, which was 3 years before high-tech was passed. And Epic was the first system to be certified as a complete EHR system that met the criteria for the meaningful use payments. They had patient portals available to all their members, before it was a requirement. In 2000, it says 2011, but around 2011, 2013, they started offering different apps to facilitate access from mobile devices to the portal. They have been offering visits to patients since 2006. And in 2015, which is years before most providers were offering video visits, they started offering the video visits. So they were, in the forefront of telehealth, before I think most of the rest of the country. And if might be familiar with the Georgia Kaiser, but Kaiser Permanente in Northern California is a different beast. It's the largest of the Kaiser regions. They have nearly 10,000 physicians, and they provide care for about 4.5 million patients. And as I said, they had been offering telehealth services for a long time, much longer than any other large health systems in this scale. And so I'm going to just go through a series of studies that have looked at, telehealth, in the last decade, and sort of built on each other and where we are now. And feel free to stop if you have any clarifying questions. But
I actually did. I'm curious, do you have a sense of why Kaiser is incentivized to be an early adopter? Like what about their patient population, sort of about them made them at the forefront of this movement?
Yeah, that's a great question. So Kaiser is an integrated delivery system. So they are the health plan, they own the hospitals, and they hire the providers. And most Kaiser providers are paid salary. Mm-hmm. And so the incentives for anyone that works at Kaiser are very different for someone that works on the traditional fee-for-service system. And so their incentives are to, I think, better align with high quality, high value care. And I think because of that, they do have this additional incentive to offer these channels of care. And anything that they do that prevents an in-person visit or hospitalization, it's going to benefit the system. It's not going to cost their bottom line because they are the insurer too. Gotcha. And so the first study that I'm going to talk about is a survey study that we did to try to understand how much of the differences in sociodemographic characteristics that we see that in portal use are explained by differences in internet access. And so to do this, we did a cross-sectional survey. This was more than a decade ago. And we surveyed all adult patients that were part of the chronic disease registry. So they had either asthma, CAD, CHF, diabetes, or hypertension, who had stable insurance between 2010 and 2011. And we asked them about their preference for accessing healthcare. So would they prefer in-person or telehealth, and then asked them about access to the internet.
So these are Kaiser adults? Okay.
Yeah, Kaiser adults. Yeah, and we interviewed about 1,000, we had an 87% response rate. And so the main findings from this is if you don't adjust for internet access, you see these big differences by age, race, and income. So for example, younger patients, 76% under the age of 44 were using the portal for send secure messages versus only 48% of those 65 and older. White patients had a higher rate of use of secure messaging compared to other groups. And higher income patients also had a higher rate. But once we adjusted for internet access, those differences were much smaller and they were no longer statistically significant. And then we did a formal mediation test to understand like how much of the difference was being explained by both internet access and preference for accessing care. And what we found is that most of the difference was explained by whether or not the member owned a connected computer in their home. You can see, so 52% of the difference observed by race was explained by having a connected computer. 60% for income, of the difference by income was explained by internet access. And about 40% for the differences we observed by education. Preference explained some of the variation, but not as much. And you can see here that having a smartphone, didn't explain any of the difference by race, and then a little bit of the difference by income and education. But this was done at a time when Kaiser did not have a portal that was easy to access from a mobile device. So if you guys think back to 2011, like if you open a browser on your smartphone, like they weren't designed for mobile devices, and it was really hard to navigate. So you could do it, but it was hard. So conclusions from this early work is that internet access explained most of the differences we saw in portal use by age, race, and income. We still saw some differences by education and gender. But it's important to understand what's driving limited access to portals, and then also how to expand access. And one way to expand access is to make it more accessible across multiple platforms, including mobile devices. And so that brings us to the follow-up study for this, where we tried to see how does having access to the portal through a mobile device, how does it change who's using it and how they're using the portal. So this was not a survey study. We did a cohort analysis in 2016, and a mobile optimized version of the portal was introduced. I have it here in 2013, other places say 2011, but between the last study and the study, it was introduced. And for this study, we focused on patients within the diabetes registry at Kaiser. And we looked at their use in 2016 and whether they were logging into the portal by a computer browser or a mobile device or both. And you can see here that most patients were using both types of devices to log into the portal. So 63% were using both kinds of devices. About a third, 30% were using just a computer browser, and 6.5% were using phone only. And then this other axis shows like how often they were logging in, like how many days did you log in at least once that day. And if you're using both devices, they were logging in much more often. So 30 days, they're using both versus like half if you're using a computer only or a mobile device only. And then we looked at like what kinds of functions were they using, depending on the kinds of devices they used to log into the portal. And among all portal users, most of them were logging in to look at their lab results. But a high proportion, like 3/4, were sending secure messages and 2/3 ordering refills. And similar if they're computer and mobile only and computer only, but for mobile only, you know, the use of the functions was lower, and the most widely used function for mobile only users was secure messaging. And I think what's most interesting about this follow-up paper is looking at who were the patients that were accessing the portal only by a mobile device. So those are the patients that weren't using the portal before. This is what this figure shows. So it was about 7% that were mobile only users. You can see that younger ages were more likely to be mobile only. So 12% versus only 4% for ages 65 and up. Also, Black, Hispanic, and Asian members were more likely to be mobile only compared to white, living in a poor neighborhood. And then this last one we looked at, we created a measure of high health engagement, which is basically if the patient was adherent to their oral medications for their chronic conditions in the last year, and if they received all of their preventive screening services in the last year, we categorize them as being highly engaged patients. And 58% of members in this cohort were categorized as being highly engaged. And you can see that not being highly engaged, they're more likely to use a portal via mobile device only. So in conclusion, you know, mobile access did help bridge some of that digital divide and bring in portal users that were historically most affected by the digital divide. But we still saw disparities in use.
Did you like survey them to see how many of them logged into any other kind of platform on their mobile device other than accessing their phone? Is it a matter of just being comfortable with logging into things on your phone? I don't know if that's like kind of comfort with technology or comfort with, you know, is it a behavior that just needs to be learned if someone just showed them once and they'd be much more likely to be a first-time user?
Yeah, I mean, and we have done like some surveys that ask about that. But for this, it was a cohort study, so we didn't ask any questions. We just like looked at the association. But I mean, it's also like there's a lot of research about like who's most likely to be mobile dependent and what are the implications of that. And I think if you're only access to the internet as a mobile device, I think you're just more restricted in the kinds of things you're comfortable doing. So it's harder to navigate.
Felix, really quickly, on the slide that you showed where you looked at the number of times they logged in or they opened the portal, I'm curious, like, I was trying to think through, is there like a normative, do you kind of have a normative sense of what you're looking for there in terms of, is it for?
No, because it depends, there's so many factors, right?
Right.
It depends on how sick you are, like your
Yeah.
clinical needs, like there's not like, you know, it's not like everyone needs to log in at least once a year. Like if you're very healthy and you barely need healthcare,
Okay,
there's probably not much of a benefit.
okay, yeah, I wasn't quite sure how to think about those, like that decline.
I mean,
number of clicks.
we didn't pick patients that, for this cohort, they all had diabetes, so they all had a clinical need, so
Yeah.
you think like some use is appropriate for them.
For those people who didn't use mobile phone, was it just because they didn't have access to mobile phones, or they had mobile phones and just choose not to use it?
Yeah, I think there's a lot of people that just are more comfortable logging into certain things like from a computer.
And if they didn't use mobile phone or a browser, how would they access their patient information?
Well, so they had to use a mobile device or a browser, or they are not a portal user. I think I have, in the next one, I have a slide that shows, like, there are patients that just don't use the portal.
Okay.
But yeah, you have to use one of those. And for the mobile access, you could either just do like a mobile optimized browser on your phone, or Kaiser had apps at the time that you could download that made it even easier. But then the follow-up to that study was to look at, okay, for patients with diabetes who are logging in with mobile device to the portal, like how is that changing their adherence to oral medications for diabetes and glycemic levels? And so that looked at some of the same period that we looked at before, but we looked at adults with diabetes who had a prescription for an oral diabetes drug at the baseline period, which is like through March 2015. We excluded insulin users because we just have a harder time measuring adherence for insulin users. And then for patients where we looked at changes in glycemic levels, we excluded patients who didn't have any A1C measures during the study period. And then we categorized everyone as either never having used the portal, using a computer only, or both a computer and a mobile device. And we saw that if you're using both, they're using the portal more often. This is just a screenshot of what the app looks like. But for the study period, so it's from April 2015 through December 2017, you can see that use of both a personal computer or computer browser and a mobile device increased. I think it went from less than 40% to over 60% at the end of the period. Computer only like shrank quite a bit. So most patients like got a lot more comfortable with their mobile devices at this time and started using both. Very few patients were using mobile only. And the number that weren't using the portal also decreased a little bit over time. And by the end of the study, I think it was just about 20%. And so we looked, so this is showing the changes that we found in medication adherence. The gray line shows that, so if patients go from not using the portal to using it from a computer browser only, they saw a small increase in their adherence to medication. And then if they added mobile access to the portal, that increased a little bit more. And then we also did a stratified analysis based on their baseline A1C levels. So if they had a baseline that was under 8, so in the baseline period before we started following them, you know, they also got like a small increase in their adherence, but it wasn't statistically significant. But once they were using both the portal from a computer and a mobile device, we did see a small significant increase and then a much larger increase for patients that started out with a higher baseline A1C. And then similar findings for changes in glycemic levels. So overall, this gray bar, we see that as patients moved from not having used the portal, and this is using fixed effects, so we're just comparing patients with themselves over time. So if they went from not using the portal to using it from a computer browser only, we saw some small improvements in their A1C. And if they added in like both computer and mobile access, we saw even greater improvements, like nearly double, which I think was surprising to us. We weren't sure what we would find, but I mean, it does show that they're using it more frequently and it's having an impact. And same we saw for those like with a better A1C. Initially, they saw some improvements with computer only, but only significant and much larger improvements when once they were accessing it from both a computer and a mobile device. And then larger improvements overall for patients with this higher baseline A1C. So conclusion from this was, you know, adding mobile portal access in addition to a computer browser had significant benefits, and it was associated with improvements in adherence and lower A1C levels, with improvements being greater among those with a higher clinical need. And so it shows that mobile tools, like we're reaching more patients that are more likely to be affected by the digital divide, and it's having an impact on their outcomes.
So no access reflects disengagement with care?
Yeah, it's associated with engagement with care.
So
But it wasn't like part of that measure. I mean, the engagement with care measure was from, I don't think we used that in this study, but it was a measure of their adherence to medication and preventive screenings.
okay.
Yeah, sorry, I'm curious, so I'm I'm not in the diabetes space at all, so forgive me if this is a very naive question, but so showing like those two figures that you showed were really interesting, where you see this, like, yeah, the large increase in medication adherence and the lower glycemic levels. Are you able to see how much the change in glycemic levels basically due to the access platform is like not due to the medication, whether the medication adherence is like the primary driver of that, or if there's something else going on.
I mean, it's definitely like a clear mechanism for improving glycemic levels. I don't think we did the like pathway analysis back then to be able to definitively say, but it would make sense. Yeah, so then the follow-up to this was to look at use of video telehealth visits and how that impacts glycemic levels for patients with diabetes. And as I mentioned, Kaiser was also very early in offering video visits. They were introduced, I think, 2015, 2016. And so for this follow-up study, we looked at adults with diabetes at Kaiser, in 2015 through 2016, and we followed them through 2019, so all pre-COVID. And we looked at all of their A1Cs collected during the study period between 2015 and 2019, and we categorized A1C values into different periods of exposure, before having any video visits, a video transition year. So the first year that they had a video visit, we consider that a washout period, and then after video visits, and we use person level fixed effects, so we're just comparing people to themselves over time. And this is just baseline characteristics of patients that were in this study, and this included, I guess it wasn't only adults, did I say adults? Sorry. So it included children too, but mostly adults. So, but everyone with diabetes who had A1C during the study period was included. But mostly adults, I think you can see more than about half were over the age of 65. And the other thing that's interesting here is that most of them did not actually do a video visit. So even though Kaiser was this early innovator that was providing access to video visits, and patients could log into the portal and self-schedule and choose if they wanted a video visit or in person or phone, like use was really low pre-COVID, even at Kaiser. So only like 2.2% had a video visit. Most patients had a baseline A1C measurement, and 70% had measures that were considered in relatively good glycemic control. So you can see the growth in video visits during the study period. It grew a lot, but it was still like these numbers are pretty small given how large Kaiser is, and you can tell the 2% number. It's not accounting for a lot of visits at the time. But still, we saw similar findings to what we found before. So overall, patients who had a video visit saw reductions in their A1C level by 0.15, which is pretty large. And then those with lower baseline levels saw smaller reductions, higher baseline levels saw bigger reductions. And then we also looked at people who didn't have a baseline level and how it changed before and after exposure to a video visit, and they had the largest reduction in A1C levels. So just encouraging to show the benefit for video visits.
So this analysis doesn't account for, or does account for in-person visits, meaning those who did not opt for a video visit. Were the two groups similar on their frequency of in-person visits, or?
So we used, sorry, this is work I did a while ago. We did patient level fixed effects.
Oh, so you adjusted for.
But we did have some time changing variables. I think might have captured like changes in like rolling changes in healthcare needs.
Oh, interesting.
On this.
Okay. Oh, it says including general self-management behaviors,
Yeah,
um,
I would need to look at the paper, to give you the exact answer.
but I guess in general, you would say, that, those who did not opt for a video visit access didn't necessarily have more in-person visits than those who added the video for this analysis, thereby supporting that the reduction in A1C is attributed to the video visit and not to more in-person visits.
Yeah,
Or
and the
less.
fact that we're using text effects, we're comparing people to themselves, so it's like, how does, comparing
Oh,
this
yeah,
person before
yeah.
they had a video visit to after, assuming their needs are the same, how does it impact their A1C?
Oh yeah, I forgot you were comparing the same.
Yeah.
Okay.
But there is this caveat, right, that all of this work is observational data. We can't eliminate all confounders, so be careful with interpretation.
Sorry, just a question, were these visits about diabetes only, or they could have been about anything?
Could have been about anything. But I think what we were thinking is that having video visit is just a pathway to get more care, right? Like once you have like any engagement with healthcare, I think it's an opportunity to check in on how you're doing in all of your care. And these are all patients that are in the diabetes registry at Kaiser.
And also about the magnitude of the change, so if it's not 0.15 HbA1c units, so that's pretty small, or how do you consider that, because that's.
It's 0.11 percentage.
Yeah,
Points.
0.11 percentage point reduction. I mean, it's small, but it's for all Kaiser patients with diabetes. I mean, it's a very large population, and that you're seeing any benefit from this very sort of passive engagement with healthcare, I think it is big. And if you look at among the patients that didn't have a baseline A1C, I feel like that's pretty big, and that's comparable to like some clinical drugs that we have. So video telehealth was associated with reductions in A1C and larger reductions if you had a higher need based on your baseline glycemic level or not having a baseline level. But use was still very low. This was all pre-pandemic. I think I'm gonna finish really early, but the last study I was gonna talk about is looking, it's a survey study that we had. When COVID happened, we had a HRQ grant that funded our understanding of telehealth and how patients are choosing to use telehealth and back on care. We were already surveying patients, and we paused the surveys to try to understand the impact of COVID. But also because like when COVID happened, Kaiser, like most other systems, they restricted access to in-person care. So patients during COVID, and I think for the next year, like starting March 2020 through like the end of 2021, maybe they couldn't self-schedule an in-person visit on their portal. Like they had to call, they had to meet with a provider first before they could see an in-person doctor. So it really changed. I mean, you will see, as we saw everywhere, like use of video visits just ballooned up. And all of telehealth, right? It was basically the only care you could get unless you really needed to have an urgent need to be seen. And so there's a lot of changes that happened outside of Kaiser. So these not necessarily impacting Kaiser, but as soon as COVID happened and we had these shelter at home policies and patients weren't, like businesses were closed, there were these temporary provisions made to allow all patients to access telehealth. So all insurance companies, commercial insurance, Medicaid, Medicare, they all started covering all modes of telehealth. You could use any system. It could be like FaceTime. It could, it didn't have to be HIPAA compliant. They weren't applying. They weren't going to penalize anyone for using non-compliant systems because nobody really had the setup outside of a few places in Kaiser to provide secure telehealth. And so everyone basically got introduced to telehealth, started using it. And there's a lot of flexibility too, where you could see any provider for any need. You didn't have to have an established relationship or a referral. You didn't have to be like at a rural location or a designated facility. So it really blew up use of telehealth for everybody all over. Kaiser included, but Kaiser was already doing a lot of telehealth before then. And so we had these surveys, we changed the content of the survey to try to understand the impact of COVID. This was not diabetes specific, but I thought it'd still be interesting to include, but we were looking at all adults that had a primary care visit that was scheduled through the portal. And we surveyed them between March and October 2020. And we asked about their preferred modality for getting care. So either audio only telemedicine or phone visit, video visit, or in person. And this was all like mid-COVID, but we asked them like, what was your preferred way of getting care before COVID happened? What is it now that you're, want to protect yourself and protect healthcare workers? And what do you expect your preference will be like after the pandemic? And those concerns aren't there. And so you can see the COVID shift, the pandemic shift to video visit was pretty huge. So where the other study ended, we were like around 2-3% of video visits. And then by March 2020, it was around 6%. And then it really ballooned up really fast. Into June, it was around 45%, and it stayed pretty stable, I think, through the end of 2020. And we asked patients, what is their preferred way of getting care? So as I mentioned, so pre-COVID, most patients, 69% said they prefer to get care in person. The fewest said they preferred video visits, 13%, and then 18% said phone. So this, we asked them during COVID, we said, what was your preference before COVID, and then what is your preference now? So during COVID, not surprisingly, most of them shifted their preference to some telemedicine, and most of them went to video, 46%, and 31% said phone. And then, when we asked about what do you think your future preference will be, most of them shifted back to in person. So they thought that once the risk of COVID had gone down, they would prefer to go in person again. But the biggest increase was for video visits that went from 13 pre-COVID to 23% post-COVID. And phone visits stayed pretty stable around 20%. And then this survey asked patients, to explain their preferences, and we just had some representative quotes. So for a patient that consistently preferred in person, this one said, because they can't get a comprehensive examination through video or telephone, which is, a clear limitation of telehealth. It's always going to be limited in the amount of physical examination you can do. Prefers telehealth only during COVID. They said, unless it's something that needs to be in person, I'm protecting myself and my doctor from unnecessary exposures. I think it was a pretty common feeling during COVID. Preferred in-person pre and telehealth post-COVID. So I think a lot of people just hadn't used video visits before COVID, and so they were newly exposed. And so for this one person, they said, I was pleased with my video visit. I would do more now that I've had this experience. I like that I don't have to drive or worry about parking. So a lot of people were just surprised by how much you could do in a video visit. And then someone that consistently prefers telehealth. Not everything needs to be in person. Driving to a medical office is not always convenient. I think this is the last slide that I showed. It's from the same survey, and it shows the flow of patients and how preferences shifted before to after COVID. So you can see pre-COVID, it was about 70% preferred in person, and most of the preferences went to video visits. So it's this blue flow bar here. Some went to phone, and then when you look at the people that preferred some form of telehealth before, the flow was pretty minimal. But a very small number went from telehealth to preferring in person.
It'd be interesting to know what is the denominator of visits pre versus post, meaning these are individuals' preferences. So this is one, so each person surveyed gives one response. But I wonder if they had more touch, they probably had more touches with the healthcare system, because of the availability and I guess population acceptance, like the general acceptance of video being more mainstream. And I would be interested to know if there were more people who ended up having any kind, total number of healthcare visits across both in-person and video. What was the total per person before and after?
Yeah,
And then you'd show greater healthcare utilization potentially.
yeah, and I wonder, like, we've done a lot of papers already that have looked at the post-COVID use, so I wonder if we have the numbers, but I don't have it on top of my head.
Yeah.
But I think it's surprising that it doesn't, I think you expect that it would lead to more visits and it doesn't.
It doesn't.
In a lot of the studies that we have looked at, like, what is the follow-up care after like a video visit or after a phone visit? And, there's a little bit more, but the difference isn't huge.
Okay.
So I guess, so with all of the Kaiser studies, there's this huge caveat and limitation to like interpreting our results, which is, these are all done in a single large integrated delivery system, which is very unique in how their incentives are aligned. And they also have very strong disease registry and population management programs that were ongoing before patient portals were available and all of these other telehealth modalities were available. So it's hard to say how generalizable these findings would be to other care settings. And then also it's all based on observational data. We didn't randomize people to receiving care through different modalities. So you can't eliminate unmeasured confounders. And I think that's really important when we're thinking about telehealth because, decisions around like what modality to use are so complicated, right? Like if you need to have like a very acute need, you might just go to the ER. If you're not sure, I think telehealth is a great way to talk to a trusted provider and help you figure out like what's the right place for you to go, how urgent is your need. But yeah, it's you cannot eliminate these confounders and you have to understand the outcomes in that context. But overall, just big picture conclusions, internet access accounts for a lot of the differences that we saw early on in portal use by age, race, and income. Mobile access increased the frequency of portal use and was increased use by patients that were facing the digital divide. Mobile access to the portal also was associated with improvements in medication adherence and better glycemic levels. And we saw video visits were associated with better glycemic levels. And, a lot of patients shifted their preferences for telehealth, from before to after COVID, just from having that exposure during COVID. And then I just have two more slides. The one is like, since I've been at Emory for 4 years now. I have started working with Tina Davis at Kaiser, Georgia, and she has a study that is adapting intervention from UCSF for Black that aims to improve self-management and diabetes distress for type 1 diabetes. And she's adapting it for Black young adults with type 1 diabetes. And we are doing it at Kaiser and we are expanding it to Grady. And generally, talking to Kaiser collaborators about maybe doing future work looking at use of devices and for patients with either type 1 diabetes or just insulin users, and how virtual care with and without this additional data sharing, the impact that it has on outcomes. But it's very early idea we're talking about.
William Troy in the chat has a question.
Okay.
I'll ask him to unmute yourself.
Yeah, hi. Thank you, Ilana. That was a wonderful talk. I just wanted to add a couple of things. One is I worked at Kaiser, Colorado until November of 2016 as an endocrinologist. And so have extensive experience with them. And I think you did a very, very nice job at showing kind of the differences and limitations. A couple of things that really, as I've tried to do similar work here, that's really stuck out compared to the Kaiser system, which you mentioned is one is everybody has a primary care physician. So you have one place to go to for every patient, whereas here we know how scattered it can be. I'm at UF in Gainesville, so Florida's probably, possibly even worse than you guys up there in Atlanta. A second is, as you noted, since most of the members are also work for Kaiser, anything they can do to lower the bar of having them come in to an office visit and take a half day off work, which they would have to pay for, is a benefit. So their cost structure is seen as very different than ours in fee for service. And we didn't, it was more about quality, cost, and service for the members at Kaiser versus fee for service here. And then I think those were the big ones. I think there was no barriers for me to do group visits or to manage medications, having a half day of telehealth visits for patients to manage their diabetes or other medications. And that was back in 2014, 2015. So, but excellent job, and thank you for sharing, and keep up the good work.
Those were good comments. Yeah, definitely. It's a very unique place, so it's hard to generalize, but I think because they are such early implementers of this technology, there's a lot we can learn.